Yeah. Good evening, everyone. On behalf of Emirates Skin Surgery Society, it's my privilege and honor to be host tonight for next webinar, the second webinar this year of Emirates Skin Surgery Society, and it's I'm very happy that we have tonight from Verona, Dr. Massimo Corrain, which is very good friend of mine and very good friend of Emirates Cancer Society. I want to remind you that the Italian Cancer Society was a guest society 2 years ago during our congress, and it was super successful and super friendly. And then we made really good friends. I'll not talk too much, and tonight is one very, let's say, hot topic about patient-specific fixation. And then I let you, Dr. Massimo, to give his speech. Please.
Okay, thank you. Thank you for the kind invitation. Thank you to Dr. Neboiza and to Emirates and Surgery Society for this opportunity. I'm very proud to be here. I would like to introduce my case-based lecture on patient-specific implant and 3D approach to deformities. And this will be a cases-based lecture, so I will show you some cases I have done during the last 10, 11 years. And I hope it can be interesting for you. And I would like if there are any kind of doubts or question we can approach together at the end. So I introduce myself. I'm Massimo Corrain. I'm head of hand surgery and microsurgery unit in Verona University Hospital in Italy. I work with the FESH, that is the Federation of European Society for Surgery of the Hand. So I'm a chair of a committee that is the Clinical Practice Committee that includes the Hand Trauma Committee and the Green Committee. A member of the board of the EXAM Committee for European Diploma in Hand Surgery and Italian FESH delegate. Verona is in a city in the northeast part of Italy, is between Milan and Venice. So I won't show you 2 or 3 slides on the work where I'm working and I live. This is Verona, is an historical Romanic city. So I invite you to come and visit me and the city when you want. And this is the hospital, the university hospital where I work with the surgical building. And the pediatric building is a recent hospital with new spaces and is very good also for pediatrics. We are regional reference center 24 hours on 24 for implantation for a major trauma, and it's a European hand trauma implantation center and pediatric hand reference center. And it is also an IBRA center for the fellowship. Next here, I'm honored to be chair of the Italian National Congress in Hand Surgery, and this is the first announcement. I officially can say that we'll be very proud to have Emirates and Surgery Society as guest society, so please save the date. In the middle of October 26, I'm waiting you in Verona to exchange our experience and our friendship. So going on to the presentation of this evening, I'm going to speak about the 3D planning and patient-specific implants in hand surgery. I have to give a short introduction about malunion because the most of the surgery that require this kind of approach are post-traumatic malunion. So we know that we can have a nascent malunion if it has the deformity less than 8 weeks post-fracture. In this case, we have an immature callus and established deformity and minimal soft tissue contracture. Or we can have a mature malunion that normally has more than 2 months, as a callus that is stiff and remodeled, and correction becomes much more difficult with an increased risk of morbidity for the patients. Which is the best approach to malunion? There is not the best one. There is not a technique for malunion because it depends on what we are going to treat. If it is an articular or extra-articular malunion, if we have a reverse radial tilt or a shortening of radius of ulna, a rotational or translational deformity, and it depends if we are treating a patient during growing age or if we have a ligament lesion associated, or sometimes the patient has no functional disorder. So we have to remember that the treatment should be directed to symptoms rather than radiographs. And so which are symptoms that normally push us to decide to correct a malunion? Normally is a loss of motion, a loss of grip and strength, pain. The most of the case is a ulnar pain for radial shortening, sometimes cosmetic deformity, and can be associated carpal tunnel syndrome or CRPS that make everything much more demanding. Which is the timing? The best timing to treat a national malunion is around the 6th week, and because the soft tissue are not retracted and the fracture line can be detected. And around 30 years ago, Jupiter and Ring told us that the corrective osteotomy should be performed as soon after a fracture, as it has been decided that the patient meets the criteria and the swelling has subsided and there is a good finger function. So CRPS in this case sometimes contraindicate the treatment. Or deformity like this patient, so osteotomy may be contraindicated if we have a degenerative joint changes or a fixed carpal instability or osteoporosis. And so in these cases, there are other salvage procedures that can be considered, like in this case. When surgery is an option, so when we decide to treat a malunion, we have to do a pre-op planning. So X-ray, contralateral X-ray, CT, 3D CT, and all these are detected in order to try to understand what to do in surgeries. But we can have 3D printing models. Then I used until a few years ago, and then I will show you. And more recently, patient-specific implant with the 3D and custom-made plates. This is a patient treated some time ago with a reverse tilt of radius. So we can draw on the X-ray, try to manage to understand the deformity. Look in the X-ray, the TC, then this has been approached by dorsal approach with bone graft with a normal standard long dorsal plate that in 3 weeks went to breakage with loss of reduction. This because of the soft tissue tension that often we have during malunion. And so we have to consider this, and I ask you to remind this case when we are going to see the next cases at the end with the PSI. So what about the 3D planning? I started with 3D planning in deformities around 10, 11 years ago. And it helped to understand in a better way the whole fracture line, helped to confirm the best side of the osteotomy and how to do it, and to choose the best device, because sometimes we have not or we hadn't the best plate to correct it. And so we can decide the position and the shape of the grow plate because we can see it. So we can decide where to perform the osteotomy in order to respect the grow plate. And above all, in children, it is a great means of communication with a pre-op dialogue to the patient and the parents. There are several papers in literature that say that a 3D printing and 3D approaches give a better result because of a higher precision and a shorter surgical time. This was the first model I used, so for 3D printing in a pre-op model before we had the patient-specific implant. So this is my experience around 8 years ago, and I use a chalk powder or ABS in order to have a 3D printing 101 scale for the pre-op planning. I saw that was useful above all on Madelung deformity, because the Madelung deformity is not easy to understand and to see in the best way. There are the McCarroll's criteria in Madelung deformity that help us to understand the ulnar tilt, the lunate subsidence, the lunate fossa angle, the palmar carpal displacement, and palmar tilt. Then we can have obviously a CT to understand in a better way the pattern of the deformity, and the MRI for the soft tissue, like the Vickers ligament. But with this 3D planning was necessary. This was a necessity to go and understand in a better way where to perform the osteotomy and which plate to use, because during growing age, the plate often is too large, and I had to use an ulnar plate that is shorter, is straight, and was not indicated naturally for distal radius, but for Madelung was very good. And I could use with simulating the surgery on this 3D printing. These are some surgical steps of an osteotomy done freehand with a dome osteotomy and piezo surgery. I suggest to use piezo surgery in this kind of approach because it is much safer for the bone and much more precise for the cut line. And this is what normally I go to do, and I went to do when I use a freehand osteotomy for Madelung deformities. And this is the plate that was an ulna plate because I hadn't a custom-made plate. So this is short, this is straight, and this has a screw enough to stabilize the distal and the proximal part of the osteotomy. Then in case of a post-traumatic malunion deformity, this is a patient that when he was 4 years old, now he, at this case was 12 years old with this deformity. The CT shows 52 degrees of deformity in a coronal view with a partial fusion of grow plate, but without presence of ulnar plus. So this deformity has to be approached with an osteotomy. But if we have a 3D printing model like this one that I did some years ago, I can simulate the osteotomy. I can decide the distance between the joint and the grow plate, and the grow plate and the plate. So when I go to surgery room, I already know which plate to use, where to put it, and to understand the distance of the plate to the grow plate and the joint. And this is the follow-up at 1 year of this temporary correction, waiting for definitely correction after the growing age. This is an adult that had a fracture and 3 months malunion with this deformity, and with the 3D printing we can understand in a better way in order to recognize the original fracture line, in order to go in surgery room to correct it, and to know that we can do that because the joint is not involved and because the distal part of the malunion is large enough to accept a normal volar plate, like this one, with a correction and a good functional results. And could be used also in a complex malunion to understand which approach was better, if a correction of arthrodesis, of radius and ulna. But now, after 2020, we have the opportunity of a digital 3D planning with the realization of patient customized solution on a single platform. And so in this way, we have fewer surgical steps, and the surgery time is shorter. And above all, in complex cases, we have much more good results. This is one of the first cases I did. It is an easy case, is a typical shortening of distal radius. we can compare digitally with the contralateral, so we can exactly know which is the shortening of radius, the inclination, and we can also check the articular line. And so I can measure perfectly the step of the articular malunion and decide if to go to correct only the metaphyseal defect or the articular defect too. In this case, for the age of the patient too, I decided to correct only the metaphyseal part. And so I can see that we have a gap that has to be fixed with a graft, but I can have a shape of the graft, a perfect shape of the graft that is very useful during the surgery. And then this kind of malunion can be fixed with a normal volar plate. It's not necessarily a custom one. These are some intraoperative surgical steps with the template that is radiolucent, so I can check the osteotomy line, the lengthening of the osteotomy site, the bone graft that has to be shaped like we have the plastic spacer, and then fixation in the correct way as we have planned with the template. This is another case. It is a complex malunion of a 52-year-old man that 10 months earlier had a polytrauma and several surgery of external fixator, fasciotomies, infection, and it has been stabilized. Then it was sent to me, and this was the radiological aspect. And so the option in this case was not so much, above all, because the retraction and the scarring of the soft tissues and the tendons. So analyzing the CT, the option, in my opinion, was a total wrist arthrodesis or try to align the radius for a secondary arthrodesis if the patient has pain, considering the soft tissue retraction. So I decided for this second option to try to realign, and this is the digital planning of this radius, so I can go and understand in the best way where to perform the osteotomy, how many degrees of inclination of the joint I can reach with this case, and these are the intraoperative step with a radial lengthening of 30 millimeters and the iliac crest graft. This is a check after 40 days with the patient had an improvement of the finger motion, of the pain, of the median nerve dysesthesia, and no problem in pronosupination. So the result for the patient was already good. Future option can be no surgery, so to do nothing, or a total wrist arthrodesis. Now we can do that with the soft tissue that are already aligned, or a Sauvé-Kappanji if necessary. And this is another case. I call that the evolution because I started to treat this patient with a normal approach, and then in a second step with a patient specific. This patient, when he was 10 years old, had a missed Salter iris 1 fracture in 2014. Okay, it was not treated because missed, but after 1 month at the check, they saw the Salter iris fracture, so was opened and stabilized with the K-wires after 30 days. And this is the check after 1 month. And this is the check after 2 months. So we can see the growth rate in the radial side that seems to be already with some problem. The patient come back when he's 17, in 2021 with this partial fusion of the growth plate. And we can see on the TC and the shortening of radius, and this lack of range of motion, above all in pronosupination with the radial hypometry. So this is the digital TC that show us the deformity, and I asked for a 3D printing model to go consider in the best way the deformity, the grow plate remaining, and the distance for the osteotomy from the grown plate, considering the plate that I can use in this case. So you see with this 3D printing how clear and how wood is the reconstruction of the bone. So I measured 28 millimeters of ulnar variance. And on a sheet, I simulated the osteotomy, the reverse wedge. I choose an ulnar plate, in this case, for the small dimension of the bone and the necessity to have almost free screw between the osteotomy and the grow plate that was remaining. These are some surgical steps. You see how I'm looking for some landmarks of the joints and the grow plate on the left X-ray during surgery. And this is what I really and we really need in order to go have a reference and distance on the correct place to do the osteotomy. Then the osteotomy, the plate, the reverse wedge, a percutaneous distal ulnar epiphysiolysis, and this is the final check. But the patient, when he finished the growing age, when he now is 19, so 3 years later, he come back for the definitive treatment after the growing age. And this is the condition that is similar to the one he had 3 years before. But if we didn't do that, maybe the deformity now was much bigger than now. And during these 3 years arrived the digital evaluation, the patient-specific implants. So we can see the similar cases with a digital reconstruction. And comparing with the contralateral forearm, we can check a 30 millimeter of dysmetry. And so I decided to associate an ulnar shortening in order to reduce the gap of the distal radius because of the soft tissue retraction. And so I decided to associate an ulnar shortening and distal radius lengthening in this way of 22 millimeter. This is the simulation with the marking and drill guides and the models of the osteotomy, the graft, and the pre-op aspect. And this is the plate that is a custom-made plate. So it's a plate that let me to have 5 screws in the distal part and a longer plate for the diaphysis, and is shaped with a rotational axis in order to go and restore the best axis reference to the distal ulna. These are some intraoperative steps with the osteotomy line, the pre-drill holes for the screw, and the proximal wire guides. And this is the intraoperative steps like decided before surgery with the planning and the shortening of ulna and synthesis of radius. And this is the radiological and clinical check after 2 months from surgery with a very good results in cosmetical and functional aspects. This is another case, is not is an unusual case. This is a forearm deformity. It's a sequel of osteomyelitis at radius. This patient now has 10 years, and he had an osteomyelitis, a sequel of osteomyelitis when he was 2 years old, of a trauma not exactly known, with a radius lysis. This is the radiological aspect. And the TC and the digital reconstruction of the form that shows that the hand is dislocated with the radius. We have no support to the hand, and the deformity of the ulna too, with a soft tissue, great retraction due to the osteomyelitis and the growing age of the patient. So I decided for a osteotomy and to create a one-bore forearm. So it means to take off the distal part of ulna and transfer the hand with the distal radius to the ulna in order to have an easy realignment, keeping the flexion extension wrist motion, and without to give a lot of forces to strike the soft tissues. So this is the planning of the transfer with a custom-made plate because it's very small, the distal part, and I need, in this case, I can have 4 screws, so a stable synthesis. And this is the comparison with the contralateral forearm. So I know that in a second step, I will have to make a lengthening of this forearm, but not now because soft tissue don't let me to do it. So this is the mark in a dry guide for the osteotomy, the distal ulnar simulation of osteotomy with a guide, and the final aspect, considering the rotational deformity of distal radius in order to give a correct alignment of the hand to the forearm. And the plate, in these cases, in all these cases, I have the perfect length of every screw. So I only have to ask, give me the 1, the 2, the 3, the 4, and the length is already decided before surgery. This is the radiological post-op aspect and the clinical aspect during the follow-up with a good straight alignment of the wrist and a maintenance of the flexion extension of the wrist. Then I show you a forearm post-traumatic deformity. This was a young boy. Now he is 10 years old. Now he's 70 years old. 10 years before, he had a fracture of the proximal radius. So with the TC, we can detect, with the CT, we can detect the deformity that is the proximal part of radius. We can try to measure it in order to understand how is the deformity. This is the CT and the pronosupination lack of the patient with a good disturb in the movement. But without a digital evaluation, it's difficult to see exactly where is the deformity, how to perform it, and how to fix it with the plate, because here we have the insertion of the biceps, we have a neurovascular position that could make it much more demanding. So if with the digital planning, we can understand in a better way. So we ask for a patient-specific implant and evaluation. And with that, compared with the contralateral, we detect exactly the point of deformity, the range of deformity, but I see that was an ulnar deformity too. We always have to consider in forearm deformity during a trauma, during childhood, that ulna too can have a deformity because of traction due to the interossal membrane on the ulna caused by the deformity during a growing age. So this is the simulation of the double osteotomy of radius ulna, the perfect size where to do that with the inclination, the simulation, the custom-made plate. This is the reconstruction compared with a reference and some intraoperative steps. This is to show you how the guide is fixed on the ulna, because maybe 1 millimeter of movement of wrong alignment can make a false osteotomy with a problem at the final. So it has to be fixed and very good aligned as planned. For that, we have these pins for the distance to the joint. This is the osteotomy line normally do with piezo surgery to be much more precise than I can, and the hole pre-drilled. And I always suggest interossal membrane lysis, central band lysis, to give a soft tissue restore of the movement. And this is the final check with a good 80% restoration of the pronation. This is another case of an atrophic multiple non-unions forearm deformity. This was a patient that is a sequel of a forearm fracture. When she was 8 years old, she had trauma with several surgeries. She came to us when she was 28, and we did several treatments for iliac crest, bone graft, plating, and we had some plate breakages. So plate, bone graft, plate breakage, then we saw a non-union, then a plate breakage again. So I decided after 3 surgery to go for a free vascularized fibular graft. The problem in this case was that the forearm was very short, very small, with several holes of the previous surgeries and the retraction of the soft tissue. And for the pre-op planning, the problem was that I had to decide to see how long was the ulna in order to understand how many fibular graft I had to take off. And in a digital way, I asked the engineer to realign the plate. And realigning the plate, I can measure exactly the length of the ulna and decide how many bone to take off in order to go and fix to the best bone that I can, and consider that the distal part of ulna was very small, like a metacarpal bone with some holes of the previous implants. So I asked them a custom-made plate with a strange shape, a large shape, in order to have 4 screws distally, avoiding the previous hole of the previous plate. So this is the simulation. This is the template for the fibular graft, and these are intraoperative check of the plate removal, the cleaning of the soft tissue, the template for the osteotomy, and the final check with the plate and the fibula. And this is the bone healing with a good alignment of the forearm, with a good motion. Obviously, you see the forearm, how small is it with the previous, the scarring of the previous surgery. I show you a case of Madelung. This is a Madelung that was studied and treated with a patient-specific implant. He is 12 years old, so we are treating a patient during growing age. So this is the TC that show me the position of the lunate with the subsidence of the lunate, the inclination of the radius. But with the 3D reconstruction, I can see the orientation of the radius to the ulna and simulate the correction. Consider that is a congenital deformity, is not a post-traumatic deformity. So in this case, I don't need to create a forearm like an healthy one, but I need to realign it, to give support to lunate, and avoid to go and give impingement of distal ulna, because in this case, I could disturb the pronosupination. So I can simulate. Obviously, it is the congenital deformity. Some companies have a large database to compare for consider how to perform this osteotomy. This is the simulation. This is the osteotomy line, the resection, the biplanar osteotomy in order to correct the radial wedging, the radial bending, sorry, and the inclination radius. This is our target. You see that I don't need to go and match the ulnar, distal ulnar. The template with the pins referring to the joint, and a custom-made plate. In this case, with a custom-made plate, I can have 5 screws in the distal part in order to give it much more stability I can, and the shape of the plate that help me to correct the bending of distal radius. These are some intraoperative steps that we created. We use sterilized squeezing and tourniquet. Then I suggest this approach is a Norway approach in order to be a wider view of the distal radius. Then I go in the deeper layer. In Madelung, often we have a deformity of the muscle too, of a square pronator. Sometimes we have some muscular anomalies, so I have to consider that because the approach is a little bit more demanding sometimes. Then I have to detach the brachioradialis that has to be dissected. And this is the guide that before to be fixed with the pins has already its own position thanks to some wings. You see in the image on the right, there are some wings that anchorate the template to the bone and are perfectly matching the shape of the bone. You see, there are no pins. This is the template that anchorates itself to the bone for the shape it has without pins. Now, then we have to use the reference to the joint for the position, 2 pins as trademark to the joint, in the same way I did before to have this technology with some needles, some K-wares on the X-ray and on 3D printing models I used to use. So 2 pins for the reference. I asked the engineer to put them in the lateral view because the first cases put them in the AP view. And so the pins went one in the radial artery and one in the median nerve. So it was not possible to fix in the soft tissue, but in the lateral view it's possible to do that. And so the guide is used to pre-drill on the holes. And this is the piezo surgery. And with you can check the ultrasonic frequency of the device, and you can cut the bone, the hard tissue, while leaving the soft tissue. And there is a vibration that with the water that avoid the heating of the bone. So this is the piezo surgery in the guide. Use like a template. You see how much precise is the cut. Consider that is a 12 years old Madelung deformity, so the bone is very small. Consider the pins are of 1 millimeters. Then the guide has to be removed and check the osteotomy, and I can take off the wedge that I've signed in this way. So removed the wedge, I can reduce as planned the osteotomy and check how correct is the alignment during the testing, the manual testing. Then we needed to put the screw, is like planned for length and number. This is the final check with the perfect matching of the osteotomy site as planned with the 3D printing model. And then a square pronator has to be sutured. And this is the final check in pronosupination and flexion extension of the wrist. And the X-ray check that show me the correction of the flexion of the radius with the support of the lunate as possible in a Madelung. I show you the last cases before to go to discussion and questions. Only for is a different approach, but I have a short experience with the 2 cases of a lunate custom-made prosthesis in Kimbok stage 3A and 3C. I only introduce you the Kimbok because Antuna Zapica taught us that the lunate has morphologic variability in a patient. He did the classification of the shape of the lunate, and this is only to say that the lunate has a different shape from a person to another, and the possibility to have a custom-made prosthesis of the lunate created on the specular contralateral 3D digital planning could be useful in this case, above all in young people with a Kimbok. This is the X-ray of a 3C Kimbok. You see the fracture, the deformity of the lunate. This is the TC. This patient was 22, 23 years old, so I decided or proximal row carpectomy or try to use a lunate prosthesis. I had experience of 12, 13 cases with lunate prosthesis in pyrocarbon, not custom-made, but I tried in these cases custom-made. So with the engineer, we decided to design it. The problem was how to fix the lunate to scaphoid and triquetrum, and is an actual problem of a surgeon that approach to this kind of surgery that is not easy. And I thought about 2 ways to fix it. So in this case, I asked the engineer to make a hole, as you see now, in order to pass through with a palmar gracilis graft with a tunnel to the scaphoid and the lunate. This was the planning I did with the intraoperative step, with the FRSC stripping, a scaphoid tunnel, a prosthesis, a triquetral tunnel, and a dorsal tenodesis with a Berger capsular flap suture. And this was the scheme of what I did in this patient with the postoperative imaging in flexion extension and ulnar and radial deviation. And this is the check after 10 months. I don't still have a longer follow-up, but it's only to show you how it's possible to do. And the second case is a similar case as the lunate, but I asked the engineer to do a different approach, a different hole to fix in a different way the lunate, because the problem of this prosthesis was the risk of dizzy or wheezy instability. So I decided to use a hole that let me to fix the prosthesis to the volar ligament in order to try to keep it aligned without a major deformity of its position on the scaphoid and the triquetrum. So these are the digital view that with the engineer can evaluate together with us. Is a lunate, is shaped on the contralateral in a mirrored on the contralateral. This is the prosthesis with a custom-made template. And this is the scheme or what I did on this patient with the palmar gracilis graft passed under the carpal, the radiocarpal ligaments in order to stabilize in the frontal plane. This is the X-ray and the check after 8 months with almost now a good result. So in conclusion, patient-specific implant is a recent valuation, a recent technology with the cooperation between engineer and surgeon. Is easy to obtain, and normally in 2 to 3 calls we can decide exactly what we need. Is a great help to understand the deformity site and its entity. We can have a custom-made plate where indicated, pre-modeled on the correct bones. In my opinion, indications are the most severe distal radius deformities, in forearm deformities, and in some congenital deformities. Thank you.
Okay, thank you, Massimo. It was great talk. Just yeah, thank you, Dr. Massimo. It was great talk. Just because it's in let's say you need really good engineering department, you need a really good setup in your university hospital in order to do all this 3D printing, then print the plate, because those plates, they are really looking weird, you know, they're looking totally different than any other plates.
Yes.
What is time frame? What is, let's say, from the when you start digital 3D, then you have model, then you have engineering, then you have printing of the finally plate. What is, let's say, this couple of weeks or how long it take?
Yes, normally the patient has to give us a bilateral CT with a disc. There are some, it is in high quality, so there is a standard they have to use to do that. And then I charge this CT on a platform. I normally work with 2 companies that can do that. Normally in a few days, 3-4 days, we organize a call. So the engineer evaluate together with me how to correct, where to correct. And after maybe no more than 1 week, we can have a only digital reconstruction. If the patient accepts surgery and hospital too, normally in 2 to 3 weeks we can have a custom-made plate, and so normally from the TC charging to the to the surgery, I need 1 month or 1.5 months.
You mean everything is free for the patient until they decide to get a plate, and then they have to.
In Italy, we can do that with the public health system, and with an extra budget for some hospital that treat this kind of pathology. I am lucky because the hospital where I work is a hub center, so we can have an extra budget for that, but it's free for the patient. And normally the cost, I can say the cost maybe is not a secret. For the digital plan, normally it goes from 2,000 to 3,000 euro. With a custom-made plate, we can reach 7,000, 8,000 euro in Italy. That it depends on the market aspect, maybe.
Yeah, okay. Now this, tell me, this probably audience is interested about this piezo osteotomy. How this?
Okay, piezo surgery is not a new technology. The first and most expert in this kind of approach are the maxillofacial, because they used to cut mandibular or masseter bones, and it gives a vibration with ultrasound and water to clean the part and keep it colder. And you can cut the stiff bone, but you can't cut, I don't know, muscle or nerve or the soft tissue. You can go with a blade, with the vibration, the soft tissue, and you can do damage. It's like the cast saw when that is a vibration, but it works with ultrasound, and so you can have a very thin cut, and it's very useful in osteotomy.
Yeah. Nice. And also probably for audiences, this is also my experience, important to understand. Whenever we do any kind of lengthening, you on your presentation, you saw you use like majority people, they're using lamina spreader. And then basically the most important is whenever we do any kind of, let's say, lengthening, we need time, we need to wait until all this soft tissue adopt to the, some people, they're in a hurry, they want to, during surgery, intraoperative, they want to distract quite fast, but better to wait 10, 15, 20 minutes, what's your experience?
Yeah. In my experience, normally I regulate myself on the strength I need to applicate to the spreader. So you have not to overstretch, but in all these cases, I hadn't a problem of post-operative thinking or vascular problem, because you can spread it, but you can realize when it is too much. Normally, I don't go more than 3 centimeters. That is a lot, 3 centimeters. So I prefer to stay 2.5 or 2 and 2, and to graft it in order to give stabilization to the implant. But I agree with you. You must do that gradually, and be sure that you don't overstretch nerves that could be scared in the scare of the previous surgery or artery. So for that, I like to use a wide approach with tenolysis if necessary, but normally it's not a problem if you respect it.
You use, as I noticed, always basically more or less volar approach. There is from audience question from Dr. Mineshnaik. What about using dorsal approach or some? Is there any difference? And he asked also about CRPS. What is, let's say, the maximum of lengthening? This you answered already, about 30 millimeter of radius.
Okay, sometimes I use a dorsal approach. With my experience in PSI, until now, I only use a volar one. I use several cases by a dorsal approach and distal radius without a PSI, with a normal plate that we use for dorsal approach to fractures. Is it possible? The best indication, in my opinion, is the reverse tilt of radius. So by a dorsal approach, you can correct in a better way, keeping the volar cortex in contact without creating too much extension. And dorsal approach is good if you have a ligament lesion associated to treat it together with a malunion, or if you need to do a tenolysis for a scarring of the dorsal part. I prefer not to do a double approach in osteotomies.
You won't do any kind of sandwich, whatever. Sandwich.
I think it's not necessary, because if we can use 4 or 5 screws for each side of osteotomy, and we can use a locking screw is stable enough, we don't need to go to use a double screw. Consider that the custom-made plate are a little bit deeper, larger than the plate that we use normally for fracture, are 2.7 or 2.8. So they have a shape that are much more stable than the normal plate we use for fracture. For that, I show at the beginning a case with a plate breakage because of a retraction of soft tissue. In that case, I had to use 2 screws, 2 plates. One was not enough, and so break it.
There's also a question for Dr. Isan. I think probably he meant something to, let's say, if you all previous plate, let's say ordinary plate, they're basically 2D. Only now 3D printed plate, they are 3D. Because you can correct 3D deformity with this kind of printed plate. All, let's say, competitor previously who was able to do it 3D reconstruction, basically it was kind of external fixator, it was whatever Lizaro and any kind of this 3D external fixator which are able to move in now. What is your opinion? What is this is, let's say, some new.
Okay, I love external fixation. I love the external fixation because I grew in Verona, that is the headquarters of Orthofix. So we had a lot of experience with the lengthening of and correction of the limb. I think that external fixation for correction is very good. The problem is that that the external fixation is bulking for 3 to 4 months on the forearm is not well accepted by the patient. And sometimes you have much risk more of infection for if you keep it for several months and require much more time to the surgeon during the month, week by week, for nursing and for correct it in the best way. But obviously you can do that. You must be experienced, and but it's possible external fixation. Yes, sure.
Yeah. There's question also about prosthesis. This obviously this lunate prosthesis. How long it can stay? Nobody knows.
You mean a lunate prosthesis?
How long it will last? This lunate prosthesis. Nobody knows. Yeah.
Prosthesis. I don't know. Now maybe it's passed around 1 year since the surgery. They are young patient, and I think it could be an option to avoid the proximal row carpectomy in young patient. And in literature, there are 2 papers dealing about this starting experience. And what normally they say is that if you have a problem or a lunate prosthesis dislocation, you have it during the first 4 or 5 months, then tends to keep in this position. And I think it's possible to take off it in future, maybe in a few years, maybe, I don't know, and do a proximal row carpectomy in a second step without problem.
And I noticed there are those two cases. One you put side by side graft, and another one you put front to back. Why you decide to change? You had some dream or something?
Because the side to side is not sufficient to control the dizzy and wheezy position of the prosthesis. So I decided to change anchoration in the volar side in order to maintain the prosthesis anchored to the volar part, in order to avoid this risk. And seems to be something better. It's a little bit more difficult to do that, but I think it's something better. I will tell you next future how they are going. Maybe both they will go to a proximal row carpectomy, maybe, but maybe we have kept time some years to do that in a second step if possible. Now they are working. They have both are heavy workers, and we will see.
Yeah, I think this is nice. There is no other solution. You don't give whatever people they tried, they failed, and then this is only probably this is now crucial thing how to fix them. What is you tried side by side and front back. Maybe it will be different geometry to fixing the side. I don't know.
Yes, consider that the lunate prosthesis is not a new idea because there was a company that produced that for maybe 10 years in pyrocarbon. I had an experience of, I think, 11 or 12 cases. The problem of that prosthesis too now is not produced anymore. In Europe, it's not available. And the problem was the same, the anchorage of the lunate to the scaphoid and the triquetrum, because tends to give most wheezy than dizzy instability, but it is a radiological aspect because the patient, 8 patient on 11, maybe they still have it, are working without a great problem, even if they have a wheezy deformity. I don't know if we could have the same results with the proximal row carpectomy in young people. So if possible to do that in next future, I think it should be better.
What graft you use for this one? What do you use? Which graft as a graft for the?
Okay, in the first case, an FCR stripping, okay, like LRTI stabilization. In the second case, a palmar gracilis, palmar longus.
Yeah. Okay. I think let's Massimo.
Yes, if you want, I can show you 2 slides for the FACS exam.
Yeah, this is all. This is what we talk about because Dr. Massimo is examiner of European diploma hand surgery, and then there are a couple of people from Dubai who went already for this exam, and then I think in the region we can promote also exam, and you have also some great idea how to improve, and also some medical legal cases and something.
Yes, if I can share my desk, I only have a few slides. So these are a few slides that I use to promote the European diploma in surgery in Italy, my country. You have to know that it exists since 30 years, and I think it is useful for countries without an official statement of surgeons, because if you have this kind of diploma, you can say that you are in Europe an official and surgery. It can, and surgeons, and it help to demonstrate a high standard of formation and specialization. I think it is useful for the team we are working with, because with that it is a demonstration of a high value of the team hub and of the quality of your work, and it gives much more serenity in everyday work, and it is a possible, maybe it is the last chance that we could have to study deeply and surgery, because it is a difficult exam. It has a very large test to be studied, and the question, most of question, we don't know how to answer, because no one always perfect, because the questions are most difficult. I think it has a medical legal value, because if you have attested by a European certificated diploma, you can also have much more value in Europe. and is all more and more considered in different countries and more required by hospital. And it has been recognized by CHESMA, that is the Maximus Council of Specialists of the medical assessment, and it has been recognized for the quality of the kind of examination. There is a committee of the FESH. There is the president of the committee now is Lindsay Muir, that is from UK, and the examiners are normally members of different society of Europe. Now we are around 32, 33 examiners all around Europe. The examination is done of 3 different steps. The first step is the application. So you need a lower level of specialization in surgery. You need to be not a resident, but a specialist with 2 years of working in a surgery department. You can find everything on the website of the FESH, and it is reported detailed on what you need. Then, if application is accepted, normally in 70% of the candidates, you have an MCQ test, normally is in March, and is online, so you can do that at home. And with MCQ test, there are 60 questions with 5 answers. If you pass it, normally around 75%, you go to orals. Orals are in during the FESH Congress, in the site of the FESH Congress, 2 days before the Congress. And if you pass oral 2, you have the diploma. These are the documents that are required, a lot of documents, but you can see the application online on the website of the FESH. And the logbook of operation, it has to be certified, signed by the supervisor of your hospital. These are the greens. So maybe all of you know this book that are the reference where we examiner use to create the questions and the cases that has to be discussion. So every question and every case that we propose to the candidate as a bibliographic reference of the green or in certificated publications. Since the last 3 years, there is an online self-assessment, so you can test yourself, you can check your level, you can have them from the FESH website. And okay, this is the website where you can find. And what I suggest you is to create, to study and to test yourself. The problem sometimes is the English language, because if is not your first language, sometimes you lose time in understand the exact concept that has to be required. These are all the topics that are included in the MCQ test. You can find on the website, so it's really large. And the MCQ has 60 questions, 5 answers each, so are 300 total questions. So the answer can be true, false, or blank. And almost one is correct, but not only one, so it's not so easy. And you have 2 hours. For that, normally, generally passed from 70-75% of the candidate can pass to the orals. These are the orals. Now they are 3 different oral, 20 minutes each, and are divided on topics. So oral 1 has acute trauma, oral 2 has sequels or reconstruction, and then miscellaneous for oral 3. And you do all in 1 day. This is the setting of the examination. You have 2 examiners and pad, a digital pad for the candidate with the questions, with the cases to be discussed. These are the orals that are in presence, the different position for the orals, 20 minutes for every group. And then the examiner at the end, we go and discuss all together the cases that are discussed or not perfect or that can be passed or not. Okay. So this was only an idea. I hope to having you given curiosity and maybe desire to do that, you can ask for my email to Jovanovic or to the agency in order to have my email if you have any kind of question, if I can help to upload your request, or if you have any kind of problem with the flash upload to the Euro diploma. Okay.
Asimo, thank you a lot. It was great evening, and then also it's fantastic from you that you invite Emirates Cancer Society as a guest society next year. We are a young society. We are just like 4 years society. We've been already last year in October being guest society in India just for their meeting, and hope will give some value for your society, and then to, let's say, to make more cooperation and more to share ideas more from our meetings. Also, I want to thanks Infomed company. We have new company for our organizing company. They look great so far, and then also we have our meeting together with the Singaporean Hand Surgery Society in November, and it's also, if you have some your people from Italy to come for this conference, also you're welcome. Okay.
Thank you. I hope to see you all in Italy, in Verona, for next National Congress. I will send you all the details. This is only save the date, and we will see together, and we decide what to do together. Thank you.
Thank you a lot. Thanks.
Have a good night.
Good night.